Well, hello, the internet. Yeah, welcome back to the Rock and the Hard Place. I'm Rocco, the guy with stiff person syndrome. So in this video, I wanted to go over what is stiff person syndrome. We're gonna keep this level 095 class, means it's less than basics, basically under college uh, explanation of this because what is SPS? Well, the first thing is that depending on the doctor you ask, you might get one answer or another. There's not universally accepted diagnostic criteria. So the exact signs, symptoms, and exact everything of SPS is not agreed upon yet, and something that is worked on being fixed. At the throughout this episode, what I plan on doing is just telling you a little bit about what PS is, how it manifests in different types of phenotypes, and then just a quick history of the journey that SPS as a disease has taken since it was founded. So, with that said, let's put our thinking caps on, our reading glasses on, and we'll get to work. So, in the most general way of speaking, the main cause of SBS is due to uninhibited muscle contractions. What does that mean? That means that when you have a Charlie horse, when you've gotten a cramp, and you're not an SPS patient, you have a muscle contraction, but it is inhibited. It's not gonna contract to the point of breaking bones, of tearing tendons, of doing long-term damage. You have a cramp that's gonna cramp to a certain period where it will be stopped, or inhibited, So what does it mean for SPS patients? It means that those cramps go uninhibited. So where somebody might get a Charlie horse, our Charlie horse can continue to pull and continue to pull beyond, any inhibition to the point where it can break bones, tear tendons off of bones, cause a lot of permanent damage, in bad enough episodes. We can also, because it's uninhibited, get it in both what's called the agonist and antagonist muscles, which really are just when you flex your arm, you have one muscle that's pulling, one muscle that's pushing. And we can get them in both muscle groups, which is unusual and actually shouldn't be able to happen unless you have SPS. So the cause of the unregulated muscle spasms in both the pushing and pulling or agonist and antagonist muscles could happen in one location or many. For me, I've broken my back twice due to very severe back spasms. The first one leading to an emergency back surgery. uh, I have bit of deformities in my wrists and my elbows from you can clearly see the difference here. Um, this is from constant spasming and pulling on the ligaments and muscles. So it causes, for me, a great deal of arthritis, a great deal of pain, and even if I had my SPS symptoms completely resolved, um, it'll never fix the pain that the disease had caused from me going 25 years without it. So here's where we get to the sciencey part. Um, GABA is the main neuroinhibitor that's produced in your brainstem. Again, neuroinhibitor. So something that causes inhibition, um, or stopping. Glycine is the main neuroinhibitor that is produced in your spinal column and develops out of your bone marrow. In my case, I have the glycine receptor antibodies. So what that means is basically that the glycine being the main neuroinhibitor in my spine, I'm producing an antibody to that inhibitor. And what happens is it goes up through my spinal column, da 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 da, into my brain, and it finds a neuron. We'll say that this is the neuron here. Now, on the outside of the neuron is neurotransmitters, and these neurotransmitters stop and start what is coming in and out of the neuron. Well, my glycine antibody will attach to this and actually act as kind of like a doorman and only let in what it wants, which in this case is the glycine antibody. Um, to go slightly further into it, and this is actually probably past class 095, what happens is on the other side of this neuron is an already negatively charged area. And the glycine receptor is allowing more negatively charged ions or anions into this area without allowing any positive ions in. So it's kind of like instead of having a balance, you end up getting one, if you think about a club, instead of having a balance of males and females in the club or whatever, suddenly it's only male or only female. In this case, it's only negatively charged ions. What that causes is something called hyperpolarization, sorry. And and basically what happens is it allows my alpha motor neurons to go uninhibited. So I can get cramps anywhere in my body at any point in time. Um and they'll go uninhibited and go as long as they want until that antibody releases from the receptor. At which time the receptor, it's been studied in zebrafish, which is the closest animal we can get towards human brain tissue. And the zebrafish, it's been found that once that glycine antibody comes up, the neuroreceptor, the neurotransmitter, actually resolves itself back into the neuron itself, resulting in me having less and less neurotransmitters as I go. Um, and that's where the thought of progression. Sorry, my cat wants to come in. That's where the thought of progression comes from in this part of the disease. Um, there are other antibodies for that indicate that you could have stiff person syndrome. For instance, people with GAD 65 antibodies, or the GAD antibodies, which I also do have. So I have both. I have the GAD 65 and the glycine. Um, it's a similar process there, but it happens in the motor cortex instead. So, but other than that, they're very similar mechanisms. Almost all people with SPS have an anxiety or phobia diagnosis as well. This is likely due to the lack of available GABA in the brain. This is what regulates a person's response to fear, anxiety, and depression as well. This area of the brain. So it's also thought that the GABA receptors in the brain might actually either be damaged or desensitized in some or most SPS patients, which is why the first line of treating SPS is to use something called a GABA agonist, something that either the um, helps the GAD create GABA, and or allows it to become more sensitive to the interaction between the two. So that's basically the overall science bit of it. And to wrap it up, what it causes is crazy stiffness, incredible spasming. But in some people, because there's multiple phenotypes, some people they get what's called cerebellar ataxia, which is basically a freezing of part of the uh, horrible at saying this word, cerebellar part of your brain. Um, so there's five suggested different categories of SPS. There's the classic SPS, partial SPS, SPS plus, clear cerebellar ataxia, which I just said, and term, or what's called progressive encephalomyelitis with rigidity and myoclonus. All it really means is that things get worse. We'll go through just a quick history of the major events that happened with SPS, starting in 1956, where it was first described by Frederick Moersch and Henry Woltman and labeled it stiff man syndrome. It wasn't until 1963 that they found the first therapeutic effects from a drug. The drug was called diazepam. That's one of those GABA agonists that we talked about earlier. Um, in 1988, so 1963 is when they found their first drug. It wasn't until 1988 that Dr. Salamina and the rest of them discovered elevated GAD65 levels in SPS patients, finally making a link to understanding it as an autoimmune disease. As if you have elevated GAD levels, it's highly likely that you have some type of autoimmune disease, usually type 1 diabetes, but there's, some others that are related, obviously, SPS and some other things. In 1989, so the year after, the first use of plasmapheresis was as a modality of treatment was first documented. So the treatments that I'm on now haven't changed since 1989. In 1991, the term changes from stiff man syndrome to the gender neutral stiff person syndrome. And this is considering that about 80% of the people, estimated 80% of the people with SBS are actually female. Um, in 1994, IVIG is the first documented use of IVIG in people with SBS. So between 1989 and 1994, I'm on both of those treatment regimens as of now. So that's how old these treatment regimens are, how outdated they are, and how much further we need to go. Uh, in 1996, another antibody called anti and if you ask me to spell that, I'll spell it different every single time. It was identified as a cause of stiff person syndrome in cases of people with cancer, which is called paraneoplastic. So paraneoplastic and stiff person syndrome, because the cancer is causing the stiff person's symptoms. In 2009, the term stiff person syndrome starts being described as stiff person spectrum disorder because of the extended phenotypes that have been realized and allowed the phenotypes to go beyond just what was the classic SPS and go to what we described above with the multiple categories. It wasn't until 2016 that the glycine receptor antibody assay, which is just a assay, is a medical term for lab test, became commercially available, identifying a strong antibody for SPS and phenotype categories. So it wasn't even until 2016 that they would have found the uh, the the main cause of my SPS anyhow, even though in 1956 the disease was first found. And then just going on into the 2020s and what's happening currently, Celine Dion has been diagnosed with stiff person syndrome, and that's brought a lot of awareness to the disease. And her donations towards SPS research um, have helped, uh, you know, um, a lot with clinical research. So, current clinical trials of multiple varieties, from stem cell transplants to CAR T therapy, and further, have started. There's also a big push by the Stiff Person Syndrome Research Foundation to create universal diagnostic criteria because there isn't any. What happens when you have universal diagnostic criteria? Well, when you have that, you have easier ways of identifying if somebody has stiff person syndrome or not. That might lead to being able to easily identify which phenotype you have, which might lead to which treatment options are best for you. Because currently, anybody with SPS just is on a constant trial. We're constantly going through different modalities of treatment, different drugs, different processes, just to see what works and doesn't work because we have no idea. It'll also lead to quicker diagnosis times, and this is one of the biggest problems. The average time to diagnosis is 7 years. Mine took 25. But currently the average time is 7 years. And originally the disease was thought to affect about 1 in a million people. Um, Recently the University of Rocky Mountain, Colorado, uh, I hope I got that right, came out with a study. It was by Dr. Amanda PK, that opening up the diagnostic criteria, uh, it could be possible that the disease is actually more closer to 1 in 100,000 people versus 1 in a million people. So tenfold, 10 times the amount of people. So probably somewhere in the middle there is the frequency of people, with SPS that are either have light phenotypes or light symptoms that aren't being recognized as anything other than having a couple cramps. So with that being said, um, I hope that you were able to understand a little bit of what I said here, a little understand what stiff person syndrome is and how it affects um, bodies. And with that, I want to say have a great day. Thanks for watching. Take care.